Hello everyone, I can see everyone joining. Just wondering, while everyone's logging in, if you would mind going into the chat box and writing your job role and whereabouts in the country you work. It'd be just nice just to get a bit of an idea of where everyone's from. Thank you. Welcome, Nikita. Welcome, whoever that is from West Sussex. Welcome, Philip. So there's 170 people signed up for today. So I was going to give a few people some time to sign in. There's about 40 people signed in so far, which is lovely. Welcome, Erica. Katie. Dintu. Welcome, everyone. Esther. Hi, Julie and Linda. Hi, Debbie. Oh, it's flying through now. Hi, Carly and Gemma, Karen, Jade. It's nice people from all over. Hi, Holly and Lean. Hello, Shem. Hello, Ellie. Hello, Samira. If I'm pronouncing this right. Hi, Sophie. So lots of DISNs coming in. It's lovely to see you all. Hi, Sandra. And Kasha. So we'll just hold on for another minute and then we'll get cracking on. Hi, Leo. Evening, Charmaine. Hi, Neethu. Hi, Helena. Thank you all for joining this evening. I appreciate that everyone's coming in after a long day at work, I'm sure. So appreciate that. Well, I'll let that go up in the process. So I just want to say a big welcome and thanks for joining this evening. So today's agenda, so we're going to have an introduction to the DISN UK group and the basic by Professor Jerry Raymond, and then we're going to have the DISN committee talking, and then we're going to finish with Phil Newland-Jones looking at the future of inpatient diabetes care. Now there's going to be time after each session for Q&As, so please feel free to use the chat in there and we can go through those after each session. So this is us, this is the DISN UK group. And so for those that don't know, we were established as a group back in 2004, and we've got members across the country, so from England, Scotland, Wales. And our mission really is to develop, inspire, support and empower our fellow DISNs, and we hopefully aim to achieve this by helping to develop some tools, resources and education packages to help you guys there on the groundwork, doing the day-to-day stuff. And also to grow and strengthen the DISN group, because we're obviously a small but growing breed, and we want to support each other in our roles. And hopefully we want to enable and facilitate the sharing of best practice. So there's lots of guidance out there, which we're hopefully going to be involved with as well. So we want to make sure that everyone's aware of these and how it impacts us as DISNs on a day-to-day basis. And we're really keen to be listening to our members' needs. So we really want you guys to be involved in the discussions and the work that we're going to be trying to do. And also trying to highlight the importance and complexities of the DISN role, and our workforce and banding issues, because obviously we are quite an acute setting, so we want to make sure that there's training out there for us. And our aim is to have collaboration with other relevant national groups. So within the DISN UK group, we've currently got 375 members from across the country. And we're involved in a number of societies who are involved in inpatient diabetes care, such as Diabetes UK, JBDS, the NHS Institute of Improvement and Innovation, ABCD, RCN, RCP, UK CPA, PCDS, TREN UK, and the British Dietetic Association Diabetes Specialist Subgroup. And we recently sort of formed a new committee. So you've got Andrea Lake, who unfortunately couldn't be here this evening. She's our new chair. You've got myself, Paula Johnson, who's the vice chair, and we've got Esther, Amanda, Wojtek, Debbie, Vicky, and Liz, who are also members, and all have an inpatient diabetes nurse background over the years. So without further ado, thank you for changing my slide because it doesn't seem to change. Thank you. We're going to hand over to Jerry Raymond. He's a professor in inpatient diabetes care and the co-lead for the GIRFT project. Thank you, Jerry.
Thank you. Hello, everyone. I hope you can see me and hear me.
Yes, we can see and hear you.
Yes, we can.
Great. Thanks, Phil. Okay, so I'm going to just take a second to share my slides. And with any luck, you will be able to see my slides. Can you? We had a slight problem earlier.
Not yet,
quite,
Jerry.
yeah.
Has it come up?
Not yet.
Okay, let's try this one. It's funny, it says screen 2, but it doesn't come up on screen 2. How about that?
Yes, we can see that. Thanks.
Okay, great. I don't know why it always gives that problem. Okay, so I'm Jerry Raymond. I'm a GIRFT co-lead for diabetes. I'm a diabetes physician at the Ipswich Hospital. And as you're going to see in a minute, I've been involved in inpatient diabetes care for an awful long time. So don't laugh at this, but this is me. My first experience in diabetes as a registrar in endocrinology at Charing Cross Hospital 43 years ago. And I was clearly involved in some inpatient diabetes care, as well working with Madeline Russell, who was one of the first diabetes specialist nurses in the UK. So you may not realize this, but there were not many diabetes specialist nurses prior to 1980. And Madeline was a fantastic specialist nurse. She went on later to work for Novo, for Nordisk actually, introducing pumps in 1986. But that's beside, that's aside. But she and I worked on the inpatient side. We did 2 ward rounds a week around as many people as we could see with diabetes in the hospital. And actually not an awful lot were identified. So it wasn't a great task. But nevertheless, it was really instructive for me as a young registrar. At that time, we had the first blood glucose testing, which was only confined to the diabetes wards. Otherwise, that was urine testing. And we had this system called the Reflomat. It took about 6 minutes to get a result out of that thing. And it was about the size of a shoebox. Later, we had these things come in, which were test strips, color test strips, colorimetric test strips, where you put a drop of blood on the strip, and then you wiped it clean, and you kind of read it against the bottle. And this was called the Boehringer-Mannheim 1:44 test strips, where the term BM comes from. And as you know, BM is completely incorrect. When people say, oh, I'll go and do a BM, it's actually a capillary blood test, not a BM. So we need to get rid of that. Soon after that, we had smaller portable glucose meters, which could be used by patients, but also could be used by the wards. And you can see there were 5 that came out around 1983. And this was my first delve into research, where I looked at the accuracy of these meters. And you can see they were quite good, except for this particular meter. However, that was fine in the hands of an expert, so to speak. But when I went and looked at this on the wards, you can see that the results were really spurious, because people didn't get enough blood on the strip, or the strip wasn't wiped properly, and so on. So it was a potential problem in terms of looking after patients and deciding on insulin based on these results. So this was my first input into innovation. So I designed this little device where you could suck the blood up into this chamber by capillary action, and then as you pull the strip out, it was wiped clean, and you can see it produced a much more accurate result than these sets of results. And this we published in the Lancet, which is great, but it never really was taken up. However, it was a forerunner of the electrochemical capillary field device, which is now part of all patient blood glucose monitoring. They all prick their fingers, touch the strip, and it's filled in the same way as the device I described. So that's a little bit of an aside, and it just shows you the start of my interest in inpatient diabetes care. Now, I became a consultant at Ipswich Hospital, and clearly I wanted to deliver good care for my patients. And I began to become increasingly concerned about the feedback that I got from my patients about the kind of experience they had in the hospital. And I was quite worried about this, and I was at a conference of Diabetes UK in about 2008. And there was a push at that time to move all patients out of specialist services into the community, with the Tsar of Diabetes, Sue Roberts, saying we actually don't need specialists within the hospital. Specialists should be working in the community. And I've really got quite angry about this, because we do need specialists to provide an inpatient service. So we have a consultant meeting at Diabetes UK, and it was then probably the BDA, usually an hour at lunchtime. And I got up at that meeting and I just expressed my concern about this. Really surprising to me that my consultant colleagues didn't actually recognize this as a problem. And actually, people said, what's wrong with Jerry? He seems a little bit depressed about this whole business about inpatient diabetes care. Fortunately, Rowan Hilson, who was then the new Tsar of Diabetes, also had some concerns and spoke to me and said, look, I think it would be really good if you feel so passionate that you should become the NHS clinical lead for inpatient diabetes. And Anna Morton then was the chair of the NHS diabetes project. So I was really pleased to work with both of them. But it's great to be asked to be an inpatient lead, but actually you have to show that there's some sort of, one, as I needed to show that there was a problem, and two, that, was I just making this up? And two, was I going to affect a change? So from that, I came up with the idea of the NADIA, the National Inpatient Diabetes Audit, which you probably all know about. And the idea was that teams would go out on a single day, they'd choose it in a week in September, and they'd go out to the wards and identify all people with diabetes and have a look to see what sort of care they were receiving and what sort of harms they were coming to in terms of hypoglycemia or hyperglycemia and so on. So I suggested we do this, and it was kind of greeted with a bit of horror. People won't have the time to do this. You'd be really lucky to get 20 or 30 hospitals. And I said, well, that's fine. At least we'll get some evidence from 20 or 30 hospitals. We set out all this publicity, informing people about it, including sending it to the hospital managers and so on. We didn't get 20 hospitals. We got 214 hospitals. There was clearly an interest in delivering better inpatient diabetes care. The result of that audit was that, first of all, there were far more people with diabetes identified than had been expected. So there were thought to be about 10% of inpatients with diabetes. It was 15%. A third of these patients are over the age of 30, over the age of 80. A third are insulin treated. A third have a treatment error, an insulin treatment error. Hypoglycemia is extremely common, a quarter of patients. Foot inspections were not being done, and many patients developed a foot complication. So that was the initial evidence, and that really provoked some exclaim amongst people within NHSE and also our colleagues. So it really did raise awareness, but also the audit was used to benchmark and to engage teams. And it really was there to support the development of inpatient services. And I have to say the feedback from teams has been great, because they really enjoyed spending their day together to learn about what was happening on their hospital wards, and actually to come back and actually try and problem solve and think about how they can improve things. So the audit went on from 2009 was the pilot, 10 was the official audit, until 2019. So let's fast forward to 2019, when the last audit was held, to see the impact of the audit. First of all, you can see that in 2010, about a third of hospitals didn't have any inpatient DSNs, and they relied on a reactive process where nurses and outpatients would be phoned up about someone who had a problem on the ward, and when they finished clinic, they'd go up to see that patient. That is reactive, and it's not actually knowing the people who are likely to get into problems and going and addressing the problem at an early stage. In 2019, that had reduced to 18%, so it was the raising awareness was effective. The other issue was a weekend diabetes service, and we only started recording this in 2015, and you can see that has improved, but many places do not have a weekend diabetes service. And many of you will have heard me say diabetes doesn't go away at the weekend. What was good was to see that, and this goes from 2010 up to 2019, you can see for people with diabetes, with type 1 diabetes, nearly 90% were being seen compared with 65%. These are people who are deemed to be appropriate to be seen by the diabetes team. And overall, it had gone up to 75%. Really important was drug errors. And you can see that all the drug errors, insulin prescription errors, errors around oral hypoglycemics, management errors, insulin management errors, and oral hypoglycemics, all fell, particularly when you come to one of the troublesome areas was units written as U, which could be misinterpreted. And you can see that significant reduction in there. Use of intravenous infusion considerably improved across all areas related to insulin infusions, and hypoglycemia reduced, particularly severe hypoglycemia, and hypoglycemia, that's less than, this is less than 4, less than 2.2, and this is severe hypoglycemia requiring rescue treatment. So the audit undoubtedly raised the issue and improved care. Nevertheless, by 2019, we still have 150,000 events of mild hypoglycemia, 60,000 of severe hypoglycemia, and 10,000 people needing rescue. One of the other things we collected was what's called good glucose days, where you had no result less than 4 and none greater than 11, and you can see that that significantly improved. Unfortunately, one of the real downsides was that that diabetic ketoacidosis did not improve at all, with around 1 in 30 people with type 1 diabetes developing diabetic ketoacidosis in hospital, and around 1 in 500 people with developing HHS, and you see the rates have not changed. So we learned a lot from the Nadia, and within my own hospital, I was concerned that we didn't have an inpatient diabetes specialist nurse. We did have one, but KPMG came around when the hospital was in trouble and said, you don't need that person. And I was really annoyed by this. So I went, and Becky Reeve, I challenged, and then I've challenged her on several things. And I said, Becky, if you in Sanofi really want to make a difference to patient care, invest into something which is not going to promote your drugs, but will improve better care. And I was very lucky to get an unrestricted grant from Sanofi to run an inpatient project, which we called the DICE project, the Diabetes Inpatient Care and Education Project. So we managed to get 2.5 full-time equivalents. We ran a 7-day service. And one of the great things about this team is we met frequently to kind of thrash out the issues and try and problem solve and actually come up with things which we thought would solve some of these problems. So we had an 8-page booklet produced, which I'll show you in a minute, which went through all the major issues. So this is what the booklet looked like. Every patient had one of these, something to do at the beginning, how to manage hyperglycemia, how to manage DKA, patients on steroids, insulin charts. At that time, remember this is 2012, none of this really existed. And the other great thing that we did was to introduce networked blood glucose meters. And again, this was pretty rare in the hospitals. And we were able to identify all patients with low blood glucose and target those on the early rounds of the inpatient nurses. So they downloaded all this stuff first thing in the morning. And then there were, for the bedside, the nurse at the bedside, there were instructions on the meters as to what to do with out-of-range glucose values. The meters were also really valuable in identifying this particular problem, which wasn't known to exist prior to this. So we looked at all the blood glucose results over a 24-hour period and found that 70% occurred between 9 in the evening and 9 in the morning. And this is because our patients are not fed the same kind of food at home, and yet they're given the same drugs. So they have a high risk of going hypo. So one of the things we introduced was reducing the basal insulin at night and a nighttime glucose snack. Not glucose, but carbohydrate snack. You can see within our own program, there was a significant reduction in insulin errors, a significant reduction in all types of hypoglycemia. And really importantly, if you take harms to patients with diabetes, you can see that there was a significant reduction in one or more of these various harms. The other thing we introduced was the Ipswich touch test, which some of you may or may not know about. That's really been taken on by Diabetes UK and the American Diabetes Association, and it's part of the 10-point training from Ruth Miller. That has also reduced our patients who acquired a foot lesion in hospital. As a result of all of this, you can see length of stay significantly reduced in the people with diabetes. It did reduce to a certain extent in people without diabetes, but the reduction was significantly greater in the people with diabetes. And this particular paper was really important in directing services to look at the importance of having a system such as this, and particularly inpatient diabetes specialist nurses, in impacting on things like length of stay. So working with Diabetes UK, Emma Watts and myself wrote this document called Making Hospitals Safe for People with Diabetes for Diabetes UK, and we gave 25 points which were important, 25 recommendations to improve inpatient diabetes care. So I've talked about GIRFT, and GIRFT is about reducing variation and trying to get people to improve what they're doing. And one of the areas we focused on was inpatient diabetes. And in our GIRFT specialty report, the specialty report was created after we'd visited between 2019 and 2018 and 2020. We visited 104 hospitals across 134 hospitals in England to review their diabetes care, and including their diabetes inpatient care. And so the report was based on the information that we gleaned from those visits. And what we have recommended is actually no different from the recommendations that we produced in the Making Hospitals Safe recommendations. And I think most of you will know these about inpatient diabetes services, cover at the weekend, meeting to discuss insulin errors, having quarterly trust diabetes safety boards, audit of harms, medication errors, length of stay, readmissions, ability to identify all admissions with diabetes and triage those who are highest risk to the inpatient diabetes service, and having an integrated way between glucose meters with alerts, everything that I've told you previously. Training, and this is really important for everyone who prescribes and administers insulin, perioperative pathways, and promoting self-management. This was actually taken on by NHS England as part of their long-term commitments to have multidisciplinary foot teams and diabetes inpatient specialist teams. And so, as you know, there was transitional funding to support the development of inpatient diabetes teams. And I'd like to think that some of the work we've done has been really influential in delivering this. So I gave you some of the initial information about 30% having no diabetes inpatient specialist teams. This is the end of Nadia. And then since we've had GIRFT and the NHS transformation funds, it's significantly reduced. We don't know where we are in 2023 because we do not have Nadia at the moment, or we haven't got the recent information. Weekend services, you can see that. This is where I showed you last, 17%, that's nearly doubled. So hopefully that will have doubled again, but I do not know. So 68% at that time in 21 didn't have an inpatient diabetes service. Around systems to identify all patients with diabetes, it's only 51%, so significant room for improvement. Triage, those at risk, 71%, got to get up to 100%, and web-linked glucose meters, only 56%. So a lot of room for improvement. One of our recommendations was around reducing insulin error through staff training. Great, we've got some really good training programs. We've got the CDIP program, we've got a hypo awareness week, and we've got insulin safety a week. And we've had a number of quality improvement training sessions around insulin safety from the College of Physicians, NHS Digital, and Diabetes UK. But still, this is not mandatory. And I'm absolutely convinced that if you can have fire lectures when no one in my lifetime in working in the NHS has died in a fire, why this is not mandatory. So hypoglycemic episode, I told you, reduced, so this goes to 2019, but we can track it further through Nadia Harms, or NDISA, and you can see that that's reduced further, so hypoglycemia is trending down. Diabetic foot lesions, as I mentioned before, have improved, and that's trending down again. So we're continuing to see improvements, but I suggest we have to be very careful about the data from Nadia Harms, because you're going to see that of a total of 361 potential places that should report, only 70% were reporting. And in the last year, of 220 who should be providing data, they might have submitted data in the last 5 years, but now only 6% are submitting data, all their data in the last 12 months. So the data that we get from Nadia Harms or NDISA Harms, we have to be careful, but it does allow us to at least track something. So reflecting on Nadia, what's missing? Well, we don't know what the prevalence of diabetes is now. It was 14.9, it's gone up to 18.1 in 2019. I don't know what it is in 23, but I don't know what you have a feel for in your hospital. But from my inpatient nurses, they reckon it's between 25, and we had about 18%, it's between 25 and 31%. We have no idea about the frequency of insulin errors, the use of intravenous insulin infusion, hospital-acquired foot lesions, good glucose day, medical versus surgical metrics, and I'll come to that in a minute, patient experience, engagement. We've lost that to a certain extent, the engagement that Nadia had about raising an awareness on that one special day, the team working, and there was data from Nadia which influenced business cases, and many trusts have said to me, many of my colleagues have said Nadia was the one thing that helped them get their business case. If we go to those 25 recommendations that Emily Watts and I have produced, you can see that there have been improvements in virtually all of those recommendations. And one of them, which I want to earmark here, is improvements in perioperative care. And let's go on to perioperative care. So one of the things that we learned from GIRFT was actually, and this really surprised me, the length of stay, excess length of stay in medicine is about, compared to people without diabetes, is about 2 days, but it's much greater in surgery, and particularly in emergency surgery. And as I say, that really surprised me. I thought we had the more complex patients, but I don't know what's been happening here. But let's have a look at surgery and diabetes. You can see that if you have diabetes, that you have a higher mortality and you also have an increased risk of various infections. If you have poor glycemic control, so here's people with diabetes with poor control and good control, and you can see that control significantly influences your mortality and infection rates. And we also know from this study that if you improve control, and you can see improved control here on a basal bolus, compared with intermittent giving Nova rapid when the blood sugar is high, there's a significant benefit in terms of things like wound infection and a composite of all those complications. What we also know is that things generally are worse on the surgical wards because maybe the surgical junior doctors and nurses are less experienced in diabetes, but also, and reflecting at what happened in my own hospital, all our inpatient nurses, diabetes specialist nurses, came from the medical wards and were far more familiar with their colleagues on the medical wards and had greater influence on them than on the surgical wards. I'll come back to that. in 2011, myself and various others produced this document for the JBDS on perioperative care and what should happen from referral from primary care to discharge. It was really welcome, that document, but never implemented. Certainly not in my trust and many other trusts. And out of frustration, we went to MC Pod and said, look, you really need to look at inpatient diabetes perioperative care. And they produced this report called Highs and Lows, and you can see 65% of organizations had room for improvement. That stimulated the Academy of the Royal Colleges, saw that report and were pretty alarmed by some of the information in there, and it directed the College of Anaesthetists to develop pathways and guidelines on perioperative care for people with diabetes. And so this was the CPOC guideline, which came out in 2021, which I was party of to this, together with a really multidisciplinary group. So fantastic document, but again, the hurdle of influencing and implementing it. Just like the JBS guidelines, it went from referral all the way through to discharge. So here's our problem. So I've said to you that I kind of tried to get a JBS document implemented in our hospital, but it was received, but we have no problem by both the surgeons and the anaesthetists. There are no issues. They don't see the issues because we pick them up later on. So I often say that, you know, the surgeon and anaesthetist look after the patient from the time the theatre doors open to the time the theatre doors close, and after that it's up to the junior staff and the ward nurses, which I think is really pretty poor. So how are we going to implement this? And myself and Emma Page, who was my implementation manager, worked with me in various projects prior to this. We came up with the idea of actually empowering the patient and getting the patient to know what to expect. And so to do that, we produced what's called a perioperative passport, and that includes all the information around things like what you should do with your medication prior to surgery, what kind of blood glucose control we should be looking at, what blood glucose control will happen in the hospital. So it can be difficult, for example, we say, and we might run a slightly higher blood glucose than you do at home because we want safety. Things around insulin infusion. So, for example, how long will I be on intravenous insulin infusion? As soon as you're able to eat and drink normally, the infusion should be discontinued. If not, ask why not. The sooner you're back on your usual treatment, the better. Now, initially, this passport was not welcomed by pre-assessment nurses, nor the surgeons and anaesthetists, or those on the wards. They thought they didn't need this. And so when we tried to get them to introduce it, they wouldn't do it. So what we did was we got hold of all the theatre lists, all the patients booked for surgery, and sent these booklets out, the passport to the patients, with the instruction that when you come into hospital, bring this with you and ask questions if things have not been addressed, including bring them to all of your appointments as well as your inpatient stay. That was really influential. Suddenly people were saying, oh, I didn't know that, the pre-assessment nurses, or gosh, that's useful information, I'll implement that. And suddenly there was a huge turnaround around that staffing group who really welcomed the passport. Another key thing to introducing this perioperative pathways was to recruit a perioperative diabetes specialist nurse. Initially a half-time, and one of the key things that we did here was to get someone from a surgical background rather than coming off the medical wards trying to influence surgery. And this, I think, was a really key step. So her role was to support the new pathway, to provide education support for patients pre and post-operatively, and to improve diabetes education amongst the surgical staff. She initially learned from shadowing the inpatient diabetes specialist nurses and coming to clinics, and also really important, auditing notes to try and understand the issues and where improvements could be made. So you can see we had really significant improvements. We had a reduction in surgical length of stay of 1.5 days, reduction in post-operative complications, really well received by patients, and also really well received by staff, with improvement in staff knowledge and confidence. So the next question was, that was Ipswich Hospital, but maybe it was just Rachel, our perioperative nurse, and maybe me kicking people up the backside or whatever. Could it happen elsewhere? So being a GIRF co-lead, I managed to persuade GIRF to fund this to run out in 10 other trusts. And I can tell you that this has been fantastic. So we've met with all the perioperative nurses, we've mentored them, we meet on a monthly basis still now, and look at the outcomes. We can see reductions in hypoglycemic events, 33%, reductions in recurrent hypoglycemia, severe hypoglycemic events, hyperglycemic events, 25%, and recurrent hyperglycemic events, 36%. Median length of stay for a combination of elective and day cases went down by 25%. Admissions to critical care unit, 32%. A composite of all diabetes complications such as DKA, HS, foot lesions, and dysglycemia by 70%. And really important, wound complications, 48%. And that's across 10 trusts. Staff knowledge and confidence, I won't go through the figures, but statistical improvement in all of those. And the greatest improvement was in the 2 questions which related to the management of high blood glucose. Patient feedback was absolutely excellent. So here are our teams. And the one thing I would say to you about this is these perioperative nurses were really passionate about the work and are continuing to be very passionate about the work they do. And it's really wonderful to meet with them on a monthly basis. We were really surprised. We were contacted by an American organization who'd seen this, and they said, you must apply for this particular award. And we won this award on behalf of Ipswich Hospital and the GIRF team, and were flown out to Chicago to receive this, which was really quite a nice thing, which we had totally not expected. So that was not the end of it. So we went out to the 10 hospitals. Now GIRF has been really impressed by what has happened, and we're now rolling this out across the country. And we've had webinars to all the regions. We continue to support the development. We're going up to the Northwest. In December, where we're meeting with 7 trusts, which we hope we will form a collaborative for them to introduce this. For anyone interested, please contact Emma Page. All the resources are available on the GIRF website, so business cases. So if you've struggled with business cases about perioperative diabetes nursing, they're there. They're the implementation strategies, the passports, etc. So that's one of the things that we've done with GIRF. The other thing that we're doing, so we're not just about collecting information from places and going from place to place. We also are involved in trying to produce things which will help others. So you can see we've produced a number of pathways. We've got the front door pathways, we've got a discharge pathway, and we're now working on an emergency surgery pathway. This is a difficult nut to crack. And you can see the engagement, lots of different people, including the ISMs, pharmacists, and so on. So I'm going to show you one of the pathways, and that relates to the front door pathways. And the 3 things here, one is essential checks for everyone with diabetes, the management of patients with a foot problem, hyperglycemic, and hypoglycemia. With any luck, this will work. Okay, it is working, so I'll move that across there. I'm getting better at this. So here we got the diabetes pathway. So let's have a look at someone presenting with a foot problem. So the first thing for all of the pathways is click here to be reminded of what the essential safety checks are. And I've produced this acronym called SNAC and Tickle. I don't like it. I think it's a bit naff, but if you can come up with anything better, please let me know. So the SNAC is make sure you feed the people a snack who've been on insulin so they don't go hypoglycemic sitting in the emergency department. So your old lady who's been preparing her supper, given her insulin, fallen over, broken her hip, ends up in the emergency department and go hypo unless she's given something to eat. Snack, think insulin, critical medicine, someone with type 1 diabetes, your rugby player fractured his ankle, sitting in the emergency department for 6 hours, hasn't had any insulin, will go into DKA. Check ketones for anyone on an SGLT2 inhibitor. Look at the feet, inspect the bare feet, because foot infection is a common cause of sepsis. And that's what your patient might have presented with. But if you haven't detected it by Monday, so Friday they come in with a septic, and you haven't looked at their feet, by Monday they might have gas gangrene. And I've seen that so many times. And then examine for loss of sensation, because these patients are at high risk of pressure ulcers. Okay, so that's your first step. And then, so what are you going to do about the foot problem? So the presenting symptom might be an ulcer or a wound. Is this gangrene, necrotizing infection, acute ischemic rest pain, or suspected abscess? If it is there, then you want a tissue sample or wound swab, intravenous antibiotics, foot X-ray, and immediately refer to the surgeons, but inform the multidisciplinary foot team. You and I know this really well, but you know your junior staff in the emergency department may not. Okay, next pathway is the person not with that lesion, but with an ulcer or a wound. They are unwell with spreading cellulitis. Again, your X-rays and your swabs, your tissue sample, admit and refer to the multidisciplinary foot team within 24 hours. That's pretty straightforward. And they're not unwell, very mild infection. Again, the same thing around your initial management. You can discharge those patients and an urgent review by the multidisciplinary foot team. So I think that should be very helpful for those working in the emergency departments. Let's have a look at hyperglycemia. So the patient comes in with hyperglycemia. Again, you'll keep it SNAC and tickle. They've got DKA, yes, or HHS. It gives you the pages, relevant pages in the guidelines. Now, I don't know if you've looked at those guidelines, but there are multiple pages, but here you're focused. Arrange admission, refer to the diabetes team. So you start the DKA pathway. If they're not in DKA, but they simply have a high blood sugar, you've got to get their blood sugar down. So check for ketones and give insulin according to the table. And the table is based on the blood sugar, what's known about their insulin doses if they're on insulin, and then if they're not on insulin, their weight. And you can see there's kind of a sliding scale there. Reassess in 2 hours, blood sugar still high. Okay, another dose of fast-acting insulin, reassess in 2 hours, blood sugar still high. Then you're going to go on to an intravenous insulin infusion and admit, refer to the diabetes team. If, on the other hand, your blood sugars come down, do they meet the criteria for discharge? Yes. Okay, you can discharge your patients. And then there's a support tool as to what you discharge them on, because you just don't give them one dose and send them home. No, you want to use the support tool, which looks like this. How do you manage a newly diagnosed type 1 in hours? Basically, refer to the specialist team. Out of hours, you need to give them some holding insulin and refer to the specialist team as soon as you can. For type 2 diabetes without osmotic symptoms, relatively straightforward. You'll start them on an oral hypoglycemic and follow up by the GP. If they've got symptoms, you want to bring their blood sugars down. You want some holding treatment and then follow up. And then that's for not newly diagnosed diabetes. For known diabetes, the support tool is very simple. It's just an escalation of their treatment, which is there. So that's some of the pathways. There's a hypoglycemic pathway. I won't go through this in any detail, except to say that one of the good things about the hypoglycemic pathway is there is a discharge support tool. So your patient is recovered from hypoglycemia, and this tool will help you decide whether or not they should stay in, whether they need a period of observation, and whether they can be discharged. So that is the interactive pathway, which I hope you would agree would be really helpful to those who are not familiar with managing diabetes in the emergency department. So what are we doing now around services? So we're doing what are called gateway reviews, and we're visiting ICBs, and we're using data from the model health system. And we're looking at their provision of services. And we're also looking at their things like length of stay. So here you can see the length of stay in this trust is huge for the fractured length of femur. You look at that, 26 days, much greater than expected. Length of stay in this trust for diabetic ketoacidosis, again, really high. So why is that? And we ask questions of the trust and of the ICB, the commissioners, as to why this might be happening and what can they do collectively to address this. We also look at 30-day readmissions. And just to show you what we've been doing, so we've been going around the country. So now we've done, I think that's 16. By the early next year, we will have done 21 of the 42 ICBs, so we will have done half of the work. And I have to say, it's been really interesting and stimulating meeting. So we do it on Teams, and often we'll have about 60 or 80 people from various parts of the organization, from managers, from implementation people, from people in the community, as well as those within the trust. And it's different from the previous GIRS pathways with GIRS visits where we only went to the trust. So this covers the whole of the ICB, and it really is quite engaging. Another thing that we're doing is something called Further Faster. And this is working with a cohort of trusts to try and look at some of the issues to try and get things solved much quicker. And that's why Further and Faster. And these are the first 25 trusts we've been working with. And we've been looking at their length of stay with DK. And we've been getting them to engage and to try and work out why they are so different and learn from each other. GIRFT has been really very heavily involved in the accreditation program for the College of Physicians, and I managed to get funding in the East of England because I'm the diabetes lead for the East of England network, and we managed to get funding to kick this whole accreditation process off. So the pilot was in the East of England, and that is really going very well, and I hope that you all will get involved in the accreditation program, because I think this will be a really important thing to drive inpatient diabetes care. So that's, I think, the end of my talk, but really, we really want to work very closely with you all as the ISNs. We work with JBS, and we've got the DCAP program, we work with diabetes care and so on. One of the things that I'm really interested in at the moment is SAMs. So getting patients to actually be able to self-administer their diabetes medication. And when I've been doing the gateway reviews, everyone says they've got a SAMs policy, but when I ask them, so how many of your patients do you think actually even get the policy discussed with them? And it's kind of 10 or 20%. So we're really keen to try and change that. So if any of you feel really passionate about inpatient diabetes care and feel that you can contribute to a group working around this project, and if you've got any bright ideas as to how we can get a change here, then I'm really keen that you get in contact with me. So I think that's it. That's my last slide. So thank you for listening. And there are loads of people to thank, but that's me gone.
Thank you so much, Jerry, for your time. Esther, was there any questions in the chat box at all for Jerry?
So there is one, well, sort of more of a comment, but a bit of a question. Leon says that he's really loving your electronic pathways and he'd like to produce something similar in Bath in time for them going paperless. But I was thinking that actually the GIRF pathways are available for anybody to download and use, aren't they, Jerry?
Yes, indeed. Yeah. So if you contact me, I can share the link with you. So basically, there is a link. As you saw, I clicked on the link there, and you can keep that on your iPhone in your favorites. So if you've got a patient in front of you, you just use your iPhone. You click the link, and you're straight into the pathways.
Brilliant, and thanks very much, Phil, who has in fact put the link into the chat, Jerry, for you. So,
Great. Thanks, Phil.
Oh, now there's lots of questions coming. So, we're being asked about, is there any specific data similar in Wales?
So Wales has been part of the NADIA in the past. So yes, there is data from Wales. But as I say, nothing's happened since 2019, and I'm not sure what NADIA is doing at the moment, or Wales is doing for NADIA. I'm sure they're contributing to the NADIA harms, but as I said to you, I don't know the uptake of NADIA harms.
Okay, fair enough. And the rest are just lots of thank yous and for your presentation. So, oh, hold on, there is one more question. I think we've got time for just this one more. Right. Do you think that there will be a repeat of NADIA because people thought that was very beneficial and would like one post-pandemic, Jerry?
So I was really pleased. I went to the DSN forum meeting in London, and I actually asked the question, would people like NADIA to come back? And every single hand went up in the room. So I think it'll come back, right? So we've got a new czar of diabetes coming in. We've got some pressure from that kind of meeting. We've got the information that I've just shown you that NADIA harms and NDSA is just not delivering the data we need. So I think it's very likely that we will get it back.
Brilliant. Well,
it doesn't mean more work for you guys, but it is quite enjoyable.
Well, and I think that certainly from my experience and from talking to people, it is a lot of work, but it gives you some very useful information, doesn't it, for improving your services. So anyway, Jerry, thank you ever so much for giving this talk today, and I will hand back to Paula. Thanks so much.
Thank you.
Thank you very much. So just briefly, then we're going to have a bit of a discussion, hopefully, with regards to the DISN UK group. So as we all know, the DISN role was basically implemented, and it's been proven, as Jerry's just shown us, to reduce the length of stay for people with diabetes admitted to hospital. And hopefully, it's again shown to see that we are supporting improved clinical care for people with diabetes again in hospital. But again, from speaking to other DISNs, it's clear that there's still some challenges that need to be faced and need to be looked into, particularly the banding structure within DISN roles, the fact that there's no nationally recognised training programme or competencies available for DISNs, no specific access to training and education, and some particular issues with staffing numbers and what staffing numbers are needed in each hospital setting. So I'm just going to hand back over to Esther, who's just going to talk through the JBDS staffing calculator that's been developed.
Right, thanks very much. So yes, sorry. Oh, lovely. Hi everybody. So I'm Esther. Hopefully a lot of people know me, but I now work for Diabetes UK. But I'm just going to spend a few minutes talking about the Joint British Diabetes Society optimal staffing calculator. So we're looking at the kind of present of DISN nursing. And a quick look at the sort of diabetes care accreditation program, although I see Jerry mentioned that, so that excellent segue to this one. So the DCAP program, as it's called, so the Diabetes Care Accreditation Program, is a sort of collaboration between the Royal College of Physicians Accreditation Unit and Diabetes UK, but it's heavily supported by JBDS and ABCD, so the Association of British Clinical Diabetologists, and of course the DISN UK group. And the idea is that it's working to accredit inpatient diabetes teams who meet a specific set of standards within 7 domains. So those domains are leadership and operational delivery, clinical effectiveness, but looking at the clinical processes, person-centered care, so making sure that the person with diabetes is at the heart of everything that we do, safety and risk, improvement, and workforce. So as Jerry said earlier, the pilot has been completed now in the east of England and Wales, and I know that they're just compiling that sort of final report. And the full accreditation program has actually been launched now for services to sign up to. And there's been a kind of production of some resources to help people to collate the evidence that is required for the assessment. And we hope it's really going to energize teams to kind of have a continual cycle of improvement of inpatient care. So please, have a read round if you're interested. You can find out more on the Royal College of Physicians website and on the Diabetes UK website if you Google DCAP or Diabetes Care Accreditation Program. Now, one of the things that was important for this kind of program and sort of setting that those standards of care, but didn't already exist, was a kind of robust estimate of the multidisciplinary team staffing that is required to provide a safe and effective diabetes inpatient service. So, so the DCAP team asked JBDS, who were already thinking about it, to kind of work on this and actually come up with something robust. So this work was led by Dr. Umesh Deshora from East Sussex Healthcare. And what happened is that they surveyed inpatient specialist teams asking about their current staffing level and what they thought that they needed. We had 30 hospitals respond to that survey. And so the results were then sort of verified and confirmed by doing one-to-one interviews with all of those teams that, that submitted data. And basically, as I'm sure you can imagine, the results suggested that that all of the teams felt that more staff were needed for each of the staffing groups. So based on the results of the survey, the JBDS expert group produced this Excel calculator to estimate staffing needs of sort of any hospital in sight, of any hospital site, just by kind of populating a few cells that'll give you information, as you need. Let me just see. I think I might have the. Oh, I do. Do I have it? Oh, I do. I can. Sorry, I wasn't sure whether I could move along the slides or not. Yeah. So lost my thread now. So looking at kind of producing this calculator. Now, one of the things it looked at. So when we started and we surveyed people, for example, per 100 people in hospital, consultants, the kind of average level of consultant input was like 0.24 whole time equivalents. But it was felt that, they needed more like 0.65 if they were going to get around all of the people that needed to be seen. Similarly, for inpatient specialist nurses, the number came out at 1.94 whole time equivalents, which ranged from anywhere between 1.22 to 2.6. But again, it was felt that, perhaps it was closer to 3.38 whole time equivalents that were sort of needed. And this is kind of per 100 people with diabetes. So this is what the calculator actually looks like, and I'm sorry because I know this is quite small and a lot of detail to see, but it's the best way of getting it on the slide here. Anything that you see that is green is an editable box. So you put in the data into those boxes in order to make sure that it suits your hospital needs. And hopefully, as you can see, sort of one of the first top lines under the hospital site is to enter the total number of people with diabetes in your hospital on a single day. So that's your bed occupancy, which will keep this calculator evergreen. So as the number of people with diabetes continues to increase, and so therefore bed occupancy might, this calculator will keep up with those kind of numbers. And this makes this in my opinion, much better than things that we've had in the past, because in the past they've always been based on number of beds per hospital. You know, you need one DSN for 300 beds or what have you, but that really makes a difference to, you know, depending on what kind of services your hospital offers. You know, if you're a specialist vascular centre, for example, you're probably likely to have, you know, a higher bed occupancy than if you weren't. So you can put in your staffing requirements. The calculator allows for calculation for, you know, for a multidisciplinary team. So that's consultants, nurses, dietitians, podiatrists, pharmacists, and psychologists. Through the process of interviews, we looked at, you know, the percentage of people that we thought needed to be seen by each team member. But that is, as you can see, is a green box again. So if you feel that, you know, you need more than 7% of your people being seen by a consultant, then you can change that box. If, for example, your dietitians and diabetes nurses overlap on the work that they do, you can change the percentage of people in each of the boxes. So you put that information in, and so this calculator hopefully allows for services to be flexible and adaptable. And then when you put that information in about your bed occupancy and the percentage of people you want to see, the calculator then calculates for you how many whole-time equivalents you would need for a 5-day service and for a 7-day service. And then kind of gives you the sort of number of hours that would be at the bottom. So hopefully this calculator will be evergreen. And we do encourage as many people to kind of use it as possible and put it in front of your senior managers, you know, to help argue that case for staff that you do need. The one thing we did know is that many services would not currently be meeting these staffing levels. So we are currently looking at getting the opinion of people for what staffing would be okay for the diabetes care accreditation program, because one of the standards is to meet the optimum staffing, but some of this is quite ambitious. So please feel free to contact me if you have any opinions on that. That would be really great. And so where can you access this calculator? So you can access it by clicking this link. I don't know if you get the slides afterwards, but otherwise you can also access it through the ABCD JBDS inpatient landing page. So if you were just to Google ABCD JBDS, then that brings you to the landing page, and the calculator is at the bottom of the landing page. And the full paper you can read in Diabetic Medicine. Only I can see that my reference hasn't come out properly on my slides, so I will put the DOI in the chat box. But otherwise, now handing back to you, Paula. Thanks so much.
Thanks so much, Esther. So just going on to now to our DISN UK group survey that we launched at the DSN forums last month. If you haven't undertaken this survey, take a picture of the QR code on the screen now and please fill in. So what we're trying to do is identify the needs of you guys who are the DISN members. And we're trying, again, a bit on the back of what Esther's doing with staff and numbers, we're trying to look at what the current DISN workforce looks like. So we've got about a third of our members that have taken part so far. So we've had 99 responses when I looked last week. So please pass this on. And the link for the survey has also been put in the chat box here as well. So you can pass on to your DISN colleagues. So we're trying to get as many feedback as we can. I'm just going to go through some of the preliminary results and on a few of the sections that we've looked at. It's really difficult to make this virtual, sort of interactive, sorry, on a virtual platform. But please, if you've got any comments in the, please add it into the Q&A section, and we can obviously discuss them. So looking at the first sort of results from the sort of nearly 100 people that have filled in the survey, and the majority are from England. So we're trying to encourage our DISN colleagues from Scotland and Wales also to be filling this in. But interestingly, from the people that have filled it in, you can see the majority of DISNs are working at a band 6, 7 and 8, I guess, is the consensus here, with a couple of people working obviously above that and slightly below that as well. And based on the Diabetes UK career and education framework that was made for diabetes specialist nurses in recent months and years, the framework was put in place there. So if you look at a band 5 up to a band 8, what is sort of expected of you? So some of the examples here, so that a band 6 is expected to have a diploma in a diabetes related field, whereas a band 7 is expected to have a prescribing qualification, and an 8 a master's in diabetes. So again, it'd be interesting to hear your thoughts about this and whether you think this is still the current sort of setup in our DISN team settings, and whether you are finding that in order to progress you've got access to this education. So that was one of the first results to look at. Again, we looked into whether people are prescribers, and overwhelmingly it looks like over half of us are prescribing, which fits again with the banding, I think, structure that we've been looked at, and the number of sort of band 7 and 8s that have been filling this form in. But quite worryingly, looking at the percentage of people that are due to retire who are DISNs in the next 5 years, so nearly half are going to retire. So just a thought in the chat box, if people can have a think, what are people doing about succession planning in their teams? Because obviously it's clearly needed if a large amount of our workforce are retiring in a short space of time. So again, that's one thing that us as a committee and a forum are looking into, about how we can produce some documents and some training and competencies for new DISNs, because it's clear that we need to grow our workforce, because we're going to lose a large percentage going forward. Also, we interestingly looked at some of the highest diabetes related qualifications that people had, and again, it was interesting looking back at the number of people that had a full MSc, for instance, because obviously in the Diabetes UK career framework, it suggested that people had a band 8 and above if they had a full MSc. But so again, it'd be interesting to know your thoughts and about, again, the access to these qualifications, and whether you're being recognised in your working areas for undertaking these. And I think that the most interesting results that I've looked at, basically we asked every member to see what support they wanted from us as a DISN group, and I put it into a word cloud, and I can see here that these responses are actually in line with what we see as a DISN group would like to achieve and bring across to you guys. So overwhelmingly, there's the need for support, peer support, and updated guidance for you guys there working on the ground, but also thinking about sort of best practice and maybe some competencies for new DISNs. Again, looking back at the thought that we're going to lose a large percentage of our workforce in sort of the coming years. There's also an ask for more webinars, conferences, etc. And again, that's something as a group that we are looking into to see. Just wondered if anyone's got any comments or suggestions by any of the results. Are they surprising? Are they what you think? Are they what you expected to see? So Esther, you are looking in the chat box, is that right?
Yes, I was going to say, sorry, it just took me a moment to press my buttons.
Okay.
But yeah, so somebody's saying that they have an MSc in diabetes and they're paid to do that themselves. They're a band 6, and they pay to do it themselves, and they're a band 6 DSN, and that's such a familiar story, isn't it?
It is. Yeah. I've got a DSN in my team that's doing the same thing at the moment. Which, so yes, and yeah, it's a difficult time out there, isn't it?
And it's an expensive course to go on as well, isn't it? So to be paying for it yourself, as well as then, you know, doing the work at band 6, so you're kind of losing out twice, really, aren't you? And if I can be so bold, selling yourself short. Somebody else has said that they plan to push for rebanding for a band 8. They don't actually have a full MSc, but they're working towards one.
Okay.
Somebody's asked, is there anything that the NHS is doing to fund DSNs to do masters and prescribing courses?
Again, there are various schemes out there. So you've got that FEND, and you've got the Novo Nordisk schemes, etc. There's various people that have sort of funds available, but again, it's some things you have to apply for yourself. I don't think there's anything out there that it is sort of a given, really, at the minute. Is people having to search out this funding. And again, I think that's something that as a group that we would like to look into, to actually look into the different pathways and what's available and what funding is available, and to share that with people so they don't have to go and access it themselves. We can actually signpost people to the available things to look for.
Yeah, absolutely. So a couple of people are just asking about what is the course that the band 6s, but I think, and as long as we're talking about the same thing, we're talking about people paying to do their own prescribing, independent and supplementary prescribing course. But we're also having other people saying that they're currently funding their own masters as well. So, you know, and they're saying it's very tough. I can imagine it is very tough. So somebody was saying the culture in the hospitals is to have an inpatient team, which includes dietitians, pharmacists, DSNs. So we would agree with that, wouldn't we, Paula?
Definitely. MDT approach definitely is, I think, definitely the way to go. Yeah, I work in a fully MDT team, and everyone brings something different to the table, and it definitely works very, very well indeed.
Yeah, indeed. And that's one of the reasons that the staffing calculator, you know, it includes the whole team, because I think before we'd only had calculations for inpatient nurses, and it, you know, it's not enough. You do need the whole team. We've all got different skills. So again, lots of other chat about people. It's quite sad actually to read, if I'm honest, Paula, about self-funding their own prescribing courses, their MSCs, and then not being given the banding afterwards. Although, well done, somebody whose name I'm going to struggle to pronounce, saying that they were very lucky to be supported to do their MSc at band 7, and their organisation also paid for their prescribing course. So I
think that's the theme here, isn't it? There's quite a lot of discrepancy between areas, and again, that's the thing we think we need to look into as a group. Actually, again, like we're looking for safe care for patients across the board, we actually want safe and equitable education resources for nurses across the board as well, don't we, to make sure that that safe care is happening.
Yeah, absolutely. And somebody's here talking about using the trend competencies and things, because there are quite a few documents, aren't there, to help people make sure that they've got the competencies and things, but it's that lack of funding and lack of help, isn't it?
Definitely. And that was one of the things when we had our committee meeting, we actually wanted to look into sort of looking at the brand new DISN, and then looking through the career progression up to the lead nurse, and how that looks and what training's available, etc. Yeah,
indeed. Now, I have to say, I don't know how big Lanarkshire Hospital is, but Karen here is saying that she's the only DISN in Lanarkshire, and then she's gone, but luckily she only has to cover one hospital. Yeah. And just out of interest, so next thing, so thinking about the future, which hopefully Phil will come to, but people are saying about the worrying thing about diabetes tech now coming through. So inpatient nurses both being a bit de-skilled in terms of tech, except that you potentially won't be, because it's coming to the hospitals too, isn't it, with inpatients? Do you think we'll see more of that?
Absolutely. I'm not to steal Phil's thunder. He may be talking about that, so I will let him go on to that in a second. But just to say, really, I want to just to round the section up so I give Phil plenty of time to give his session. Just say thank you for all your input. We are going to listen to everything you're saying and hopefully work as a group to try and answer some of these questions and meet some of these needs, basically, because I think we're all in it together, and yeah, we're keen to support each other, really. So I'm just going to now hand over in essence of time to Philip Newland-Jones to look at the future of inpatient diabetes care. So I have the pleasure of working with Phil on a day-to-day basis. He's our consultant pharmacist in diabetes and endocrinology at Southampton Hospital, and he's also the clinical lead for my service. So thanks, Phil, and over to you.
Hello, good evening. So I hope everyone can, someone just give me a thumbs up or a yes if you can hear me.
Yes.
Perfect. And I'll just share my slides. And if someone likewise could just tell me that you can see the slides.
Yes, we can.
Perfect. Okay, so as Paula very kindly mentioned, so I've been working in inpatient diabetes for, well, since 2010. So Jerry eminently had been working in diabetes for a long time before I came to the game, and had already started the inpatient Nadia audit by the time I'd already started inpatient diabetes. So since 2010, I've been working quite a long time, and I've worked through to become a consultant pharmacist in diabetes. So I've been given an enviable task today of looking into the crystal ball and trying to think of what the future of inpatient diabetes may look like after the fantastic discussions and talks that we've had so far. So I think if I can just get to move on. So I touched a little bit on the background, the patient journey, about medication, and I think that certainly the future of medication as well. Where I think that maybe there's going to be areas of capacity demand in the future because it's only going to grow. Diabetes tech, as was predicted, is going to be on there, and I've got just a little bit on artificial intelligence in diabetes care as well, to wet your whistle. And what we need to do is, everyone works in a different environment, and you know your hospitals better than anyone else, and therefore I want you just to start thinking about these things, because yeah, I guess as Jerry has shown, you're always more likely to be successful in the things that you're trying to drive forward if you're the person that's kind of coming to the table with ideas, not being told to do something further down the line. And I'll make reference to that a couple of times throughout the presentation. So as Jerry had pointed out, Nadia helpfully showed us that although we are improving, we still have a huge amount of medication errors, insulin errors, insulin infusions, hospital-acquired DKA, and yeah, Paula will attest to the fact that some days when we have another inpatient DKA for someone that's had their insulin infusion stopped in the middle of the night after an orthopedic operation that's happened this week in our trust, and I'm banging my head in school, why has this happened again? How is it? The amount of education that we've driven in this area, and yet we still ended up with another inpatient DKA in the circumstance. So work is not going to go away, and actually there's a revolving volume of staff in hospitals, and therefore education never goes away as well. So I think that we're always going to have a high risk population in the hospital that's growing in terms of people with diabetes. Yeah, as Jerry touched on as well, we've had this improvement in medication and prescription errors over time. I think some of that has certainly been the drive of electronic prescribing, which has been certainly in our trust. We were in a unique position in 15, 16, where we had half our hospital on electronic prescribing and half on paper at the point of Nadia. And we saw pretty much half the amount of errors on the side that had electronic prescribing started on. So for us, it definitely improved medication safety. Nadia harms, as Jerry has touched upon, is focusing on those the kind of, I guess, the things that are capturable, and we know that certainly increase both length of stay, morbidity, and cost to the NHS as well. So hypoglycemic rescue, DKA, HHS, and diabetic foot ulcers within a certain time frame. But Jerry has also pointed out, which I also wanted to touch on, that, is this the best that we can do with only 34% of trusts actually submitting since data started in 2018? It's just, it's difficult, isn't it? And I think that's the problem. Is I'm not sure it gives us a true representation of the problem still. I think it's you know not giving us a full picture. And so in our trust, I know I've got this joy next week. We've continued to run Nardu each year, slightly digitized the format, and we're due to run it next Wednesday. It's a little bit later this year. Yeah, as Jerry said, it's a joy. Looking forward to it. So thinking about the patient journey, throughout a hospital setting, they're dangerous. In reality, harm happens to people in hospital. You don't want them to be sitting there, and the longer they stay there, the more likely to end up with other infections and bits and pieces as well. So for patients, we want to make sure they've got the right sick deals at home. Throughout admission, getting the correct diagnosis. The amount of times that you will all have seen in notes that patients are either have something written incorrectly in the notes, that you'll be correcting, that we've got effective medication history. So when you look, and we did a nice audit in 2 years ago to look at our junior doctor clerking, for example, and whether or not for insulins they did an effective medication history, and only about 15%, I think it was, of juniors at that time were actually able to take a full medication history for insulin that was correct. Self-admin, as Jerry's pointed out, again, is a big problem. Some trusts have got around it using different members of staff and utilising it. In our trust, we utilise our pharmacy technicians to undertake self-admin assessments rather than the nursing staff, because they're a smaller cohort to teach. But we're lucky enough in our hospital to have a huge volume of pharmacy technicians. And they all see patients. Pretty much about 90% of patients are reviewed in the first 24 hours by a pharmacy technician taking a med history and a self-admin assessment. I guess the clinical situation, patients can be confused, AKI, nibble mouth, stress, hypoglycemia. And I think that as we're starting to build down this list, I guess what I'm trying to show is that I think inpatient diabetes nursing is difficult, and it's actually fairly specialist. You can't, if you just, with a good baseline knowledge of diabetes, you can't just jump into doing inpatient nursing. And to teach it properly, you need 12 to 18 months, I think, to be able to really fully get your feet. And even then, if you were to try and write down why you make certain decisions in certain circumstances, it's incredibly hard to do so in guidelines. It is as much an art it is a science. And, the reason you've chosen to increase that person's dose by 70% tomorrow, you would have seen that case 50 times before, and you know the reason why you're suggesting doing it. But if you try and write down exactly the reasons why, it's really difficult. So I think there's a multitude of things that makes diabetes specialist nurses, when they are fully fledged and up and running, really invaluable to a service. And I'll come back to why I think this is going to be even more important going forwards. And you'll see that, here's just 2 pictures in the last month or two of the things. Even when we've got electronic prescribing, you can start to see. So on the left-hand side, we've got the clerking written by a junior doctor here. So 5 IU looks like it certainly could be 51 units, and certainly I see people that could easily be the case. I've got patients in my clinic on 200 units of basal insulin and 50 at mealtime. So it's not unheard of. But worryingly, on the right, you'll see another example of that stat. No, so this was an example where actually my colleague, Dr. Patel, gave telephone advice, and I texted him this picture to go, did you really suggest 20 units to stat dose and overwrap? And he's like, two units. So that 0 with a dot in it is actually used abroad sometimes as a unit figure. So instead of U, they write this little 0 with a dot in it, which I find incredibly dangerous. So even when you're trying to do the right thing, you can start to see it can go very wrong very quickly. Outside of that, I'm going to show you just a couple of pictures that will just spark your mind into the problems you see in hospitals. So drawing out of insulin pens. So although I'm touching a little bit on the past, I do recall calling Jerry and a number of other people at the time to say, I think there's a problem in hospitals with people drawing out of insulin pens because they had this DKA in the top right. And straight away we saw this air bubble. And then I went around all the fridges and found some concentrated insulin that had been drawn out of. And then we spoke to a number of other groups and found out it was a huge problem across all hospitals. So a national patient safety alert was brought along, but it's still an ongoing problem. And I think that's been amplified at the moment, you'll all recognize, by the receiver shortage. Yes, that's one thing, certainly. People can't get hold of the flex pens and they come in hospital, the flex touch. Then they'll just draw out of something else. And unfortunately, it's been too long since it was last an MPSA alert that a lot of people have forgotten that it's not the right thing to do. Lipos, again, nothing quite like seeing a patient that you can solve by checking out their lipo bits and pieces. Again, something that isn't going to go away in the future. You need experience to know to look for this. So if someone looks, the doses look wrong for a person, then it's quite useful to go looking for it sometimes. And then another example of this is a particular patient that I saw a couple of years ago now that presented with like severe weight loss. Glucose levels remarkably high despite large doses of insulin. Husband was adamant she was taking the insulin. The daughter was even covertly watching her take the insulin. So we brought her to clinic early in the morning. She'd been told by her practice nurses and by the GP a number of times how to give insulin. It had been reiterated to her, but yet she was still losing weight. She was now about 44 kilograms, as you can see. Brought her in, found out she'd been actually just pressing the inner cap against her skin and injected inside the inner cap, which she was not removing. So there you can see across the 4 months, this is the weight gain associated insulin, the anabolic effects of getting things right. And so the importance of picking things like this up as an inpatient, again, you'll get to see things that others will not come across. What about the change in medication use? And again, I'm probably describing something you're recognizing already, but it's going to kind of further in this direction. So I think these are the ADA, American Diabetes Guidelines, and the European Association for the Study of Diabetes Guidelines on the management of type 2 diabetes. I think we'd recognize the word SGLT2 is written an awful lot throughout these guidelines in heart failure, in chronic kidney disease, in atherosclerotic cardiovascular disease, in those with a high, what's effectively Q risk. Pretty much everyone nowadays should probably be getting SGLT2 second line. And also those without diabetes with heart failure or without diabetes and chronic kidney disease. So there's a huge increase in the volume of this class of medicines ending up in hospitals. What you'll also recognize is that certainly I can hold a hand up quite happily and say that I definitely see more, at least ketonemia, but probably DKAs in the week now in people with type 2 diabetes on SGLT2s than I do in type 1 diabetes. And that is a complete change. And a reminder to people, it happens because SGLT2s lower your insulin levels. So they allow your body to reduce the amount of insulin because you're peeing out the glucose. So it recognizes you're almost in a pseudo-fasted state. So you get this slight, ketone generation in that pseudo-fasted state. You utilize all your glycogen stores of in the liver, and actually you only need a little bit of starvation ketosis, a little bit of dehydration, and that concentration of ketones through intercurrent illness or metabolic stress like surgery, like infection, like vomiting or diarrhea, and all of your hormones go up and say, we need some more insulin. But of course, if you're taking the SGLT2, you can't kind of surmount a response. So you're therefore relatively deficient. So you end up with insulinopenia, which leads to DKA. And of course, you're peeing out at the same time. So it's a normal glucose DKA, a euglycemic DKA. And so this is happening more and more and more in hospital settings. As a port, Southampton, we've had a couple in the last year of people that have been on crash low-carb diets, ready for their cruises, and never quite make leaving port because they go into DKA in the hotel waiting to go across on their SGLT2 inhibitors. And I've had at least 5 or 6 of that occurring. Must be a Southampton thing, or waiting to go on their cruises. But we see it fairly often. Thankfully, not really our GPs that are doing it. It's across the country and they're just traveling down to us. But it's something I'm seeing more of. Jerry had touched on perioperative controversies. And I think that the slight problem with some of this is that the lack of evidence base. So you'll all recognize that there's plenty of kind of suggestions of what we should be doing with these medicines going forwards. But the Americans at the moment have just said that actually they want to withhold metformin on the day of surgery. They want to hold all the GLP-1s either a week beforehand or a day beforehand, depending on which GLP-1, which means there might be slightly more hypoglycemia. The UK has left that advice as take as normal, but we also then do the opposite. So they discontinue SGLT2s 3 to 4 days before surgery. In Canada, it's 7 days, whereas we only stop it 24 hours beforehand, usually. And I think that there's still something to be asked about that. I think that we are starting to still see patients go into ketonemia, certainly during surgery, even though they'd stopped their SGLT2 the day before surgery correctly. So I think that there is a lack of evidence base in perioperative diabetes management at the moment, which we need to get a bit further on. But certainly something to think about in adding that onto what Jerry had already said. So I guess the ongoing concerns with this is that, we are getting more SGLT2s in diabetes, heart failure. It's not going to go away. There's going to be more patients. Hospitals and acute settings can be quite difficult for patients on SGLT2s. And I think that it also means that we're going to need to think of other mechanisms to treat people's diabetes when they come in hospital, because there's a lot of reasons why you might withhold it. And then obviously you need to replace that with another medicine, whether it's insulin or whether it's something else. We are going to end up with a lot of patients not able to have what's probably doing a decent job at controlling their glucose levels outside of hospital. And all of a sudden we're taking that away because of the acute admission. So I think that we're going to have to do more and more work, even temporarily. We may even end up getting to the point of having to write to standard guidance for the cessation of SGLT2s and what you might do, just because of the volume of how often you're going to get called about it. So I think it's going to get worse in that aspect. I think certainly the euglycemic DKA can catch people off guard, and certainly our anaesthetists only get burnt once with it, and then they are probably overly cautious in checking for it again and again and again after that. And I think, yeah, as I mentioned, I'm certainly seeing more DKA in SGLT2s in type 2 than in type 1 diabetes nowadays. What about future medicines then? And I'd say we're already in a fairly complex place, aren't we? For those that have been working diabetes a while, you would have recalled the explosion of therapies that we had between, I guess, 2013 and 2017, where loads of new insulins came out. We had the SGLT2s arriving. We had combination products of SGLT2s and DPP4 inhibitors, and it became really complicated. And people who you were previously actually happy, general physicians that were happy managing diabetes before, when it was metformin, sulfonylurea, maybe a bit of pioglitazone and insulin, all of a sudden went, crikey, I now feel out my depth. And I feel like that when I look at asthma inhalers now. You go, gosh, there's a lot of them. I don't really know what I'm doing anymore. And beforehand, it was just take a bit of steroid and long-acting green inhaler, and then you take your blue one, don't you? But it's become much more complicated. Every area of medicine has become more super specialized. So the best thing about doing these talks that aren't organized by pharma is I can actually put these sort of slides up and show you from the Lilly investor slides where things are going. So a good example here, as you'll see in the middle, so the insulin Efsitora Alpha. This is a once-a-week insulin that's in phase 3 clinical trials at the moment. We've got this, or orforglipron, and this is it works like a bit like a GLP-1, but it's not a peptide. So it's a tablet that affects the receptor agonist and will do the same things as a GLP-1 receptor agonist. And because it's not a protein or a peptide, it means you can take it orally. So it's an oral GLP-1 agonist that's not a protein. Retatrutide, or previously known as triple G, is glucagon, GIP, and GLP in agonists, all in a single injection. So a triple incretin analog. And all of these are phase 3. They're not that far off market, it's worth pointing out. And for a lot of people here, you wouldn't have heard of any of these. Maybe Empathin and the tirzepatide, not many of you have heard of, obviously, because it's quite hot off the press at the moment that arrive in the UK. So I think in the last 5 to 7 years, we've had the era of SGLT2s, haven't we? You couldn't go to a conference without hearing about them. We are now in the era of incretins. So the next 10 years is going to, whether you're talking about diabetes or obesity or NASH or NAFLD, it'll all be about incretins moving forwards. If we start to look at the phase 2, again, Lilly studies, you can start to see, again, some monoclonal antibodies being used, some amylin analogs being used. So this is another type of incretin. Higher dose tirzepatide for weight loss and NASH. And Novo Nordisk, likewise, if you look at their pipeline at the moment, you can see they've got oral GLP-1 and GIP in phase 1 results already. So this is similar to tirzepatide in an oral format. We've got insulin icodec already submitted for EU is phase 3. So we're already quite far along in these milestones. So I'm just going to pause because it said my internet connection is stable. So I'm just going to double check that people can still hear me at the moment.
Yes, we can. We lost you for a moment, but you're back.
Fine. Did you lose any of the good bits? Because I said something fantastic, obviously. Hopefully it wasn't too long. I was just saying that essentially the once a week insulin has been submitted for EU submission. We've got oral GLP-1s and GIPs en route, and combinations of semaglutide and another amylin analog that's already in phase 3. So diabetes is only going to get more complicated. So I think that we are already going to end up with more confusion with new products. We've got more incretin products for diabetes and obesity, and the now new names for NASH and NAFL, which is metabolically associated steatohepatitis and metabolically associated fatty liver disease. So for both of those, we're going to get loads of these incretins coming forwards once we have supplies back in the UK, obviously. And I think the next thing that's probably predictable with these other once weekly insulins coming forward is this prolonged hypoglycemia. I mean, everyone that's worked in inpatient care has seen the effects of Toujeo and Tresiba sometimes in causing really significant hypos for a number of days. And the problem with that, certainly if you've ever had an overdose patient with any of those medicines, it is difficult. You've got someone insulin infusion for days. But I think that once you've got this once week insulins, their half-life is extremely long. So if you do end up in a case of an incorrect dose being given, it's not something you can manage quickly. It's going to be hospitalization for a number of days. What about areas of capacity demand? And I was asked again to think about this, only because, as I pointed out, I think sometimes it's sensible to go and suggest what you might be wanting to do rather than be someone else demanding you to offer a service at a later date sometimes. So I think the first thing, which is in the last month, probably the hottest topic in any hospital setting, and I don't think anyone really fully understands, including anyone that's because I don't think the media is necessarily covering it, but even at the moment, you can already feel the pressure on the system at the start of winter in hospital settings. Pretty much every A&E around the country is at breaking point. There are no beds in the hospital, as well as the 200 plus in most large hospitals that are waiting for social care settings or nursing homes. And so I think sometimes it's worth starting to think as a team, because I think the hospital is already starting to go, what else can we do? What else can you do in those circumstances? And I think what you don't want to do is be dragged in at the last minute going, I could just go to A&E and see if you can turn some patients around. So I think start to think about how you might be able to think of ways to avoid admission in some of those patients, not necessarily going direct to A&E, but pulling them into an SDEC scenario or a specialist medicine SDEC upstairs if there's a high volume of diabetes patients. As Jerry mentioned, pulling those early DKs in so you can manage them in a chair with some fluids and other bits and pieces rather than having to admit them. And I think that only you and your hospital know about what would work, but just start to think about that in reach into A&E and SDEC. I think that we've got this problem where capacity in primary care is definitely too great for most surgeries at the moment, and you either get the choice of in a GP surgery to kind of focus on acute care or chronic management, and it's very difficult to do both. So I think at the moment we've got this issue with primary care not being able to manage, and actually what is showing at the moment is that the capacity is also too great for community services. So if you've got a community diabetes service, often the amount or the volume of people with acute problems with diabetes is too much for them to even stop admissions to hospital. What I would very happily put my hands out and say is that, and I'd be the first to hold my hand up and say, I'm not an expert in community or GP diabetes. That population size of things, I'd need support from others with the expertise to do it. I'm very good at inpatient diabetes. And I think that with diabetes inpatient nurses, you have this expertise that's condensed in very few. We've seen the numbers. There's not loads of you, but the expertise around the country is condensed, certainly when you've got hospital interventions, so NG feeds. I just think that inpatient diabetes nurses do NG feeds and insulin much better than anyone else. Very high dose steroids, so pulsed twice weekly, 20 milligrams of dexamethasone or 100 milligrams of prednisolone. There's just no way that primary care have come across it enough to be able to be confident in its management. The same goes for specialist medicines used in hospital settings, whether that's in oncology or multiple sclerosis or anywhere else you can think of. You are the experts, but that expertise is really tightly condensed into a small number of people. On that, anyone that was at the DSN conference last week would have heard me talking about alpelisib, and certainly I think that oncology is a real expansion area. They've got a higher baseline prevalence of patients with diabetes already, is worth pointing out. So it's about 20% of the patients undergoing oncological management. The light at the end of the tunnel is most services have been pushed to really start to think about rationalizing the use of dexamethasone in protocols where it's only used for the nausea and vomiting, because actually those protocols are extremely old and there's better antiemetics nowadays. And if you push some of the clinicians on, do you actually need to use the dexamethasone in this case, or could you use ondansetron instead? You'll find them going, actually, yeah, we could. We'll just skip the dexamethasone thing for here. It's for nausea and vomiting. Don't worry about it. But there's other cases that they can't, obviously. And there's certainly more medicines en route that will cause hypoglycemia or immune-related complications, such as type 1 diabetes. And the JBDS document on oncology, and again, you would have come across patients with onset diabetes after transplant with some of the everolimus or tacrolimuses. We've got the alpelisib I mentioned, where 60% is, this 37 is an underrepresentation. So it's about 60% of patients will develop type A severe insulin resistance on this medicine. We've got lots of other these NIBs and MABs and monoclonal antibodies, and of course, huge use of somatostatin analogs if you're a center that looks after neuroendocrine tumors or pituitary surgery, or even some of the intestinal failure patients. So again, it's quite difficult to manage. You have to develop the expertise in the management of somatostatin-induced hypoglycemia. And even when we've got the kind of immune checkpoint inhibitors, so nivolumab, pembrolizumab, and ipilimumab are probably the main ones. This increase in the development of type 1 diabetes, and we probably get about 8 cases a year in our hospital of type 1 diabetes caused by immune checkpoint inhibitors. So I think that we are seeing more of this coming forwards, and if there's ever an argument to kind of copy what we're trying to do in perioperative diabetes at the moment, and I guess embolden and engage and employ an oncology nurse that's able to be upskilled in diabetes, a bit like I guess the CF units have done in the past with nurses that have expertise in both CF and diabetes. Now's the time to start thinking about it, because I think that it's only going to grow. The other thing is to think about is the expertise that you have all developed in inpatient care. And as I mentioned, it can't be replicated quickly. We actually utilized some nurses from our community diabetes team during COVID. And within the first couple of days, they held their hands up and said, I feel out of my depth. And these are experienced nurses in diabetes, but it is different. And I think that going forwards, we've got a growing elderly population. So there's going to be an increase in care homes. There's going to be an increase in rehab units. And you'll have to increase capacity due to command in hospitals currently. So, with 200 patients in any hospital waiting for a bed, they're going to have to try and increase rehab units to be able to get space out of hospitals for acute care. I think we may even start to find that small hospital units are opening back up. I know that certainly our hospital even thought about buying a care home, as well as buying whole, floors of hotels to get almost well patients out of the hospital. But I think that there may be an issue about just buying small hospital units and getting them back up and running for that rehabilitation rather than having them in big acute centres. And my worry about that, and certainly something to start thinking about, is the increase in use of technology in those settings. So if we ever get to the stage where we have between 50 and 75% of patients type 1 diabetes treated with an insulin pump or a closed loop hybrid system, and they're in a rehab unit, what are you going to do? You know, because certainly the community teams aren't going to be able to manage that at the moment. And so I think it's really starting to think about policies, protocols, procedures, support pathways of how you can think about utilizing technology, not just as an inpatient setting in acute care, but also in the rehab units, in care homes. Something to think of going forwards. What about the educational demands on a service? Because with the increase in technology, I think the education is going to be one of the biggest things that has to increase in a DSN's role, because there's no way you can do all of the work. You're going to have to upskill and be clever about how you're upskilling as well. And so I take Jerry's point about mandatory insulin, certainly insulin, but mandatory diabetes education. But I'm going to put this here to start with. So you come across a deep fat fryer, still plugged in, which fire extinguisher do you use? And all of you have done this every year. You've done your fire training every year that you've been a nurse, pretty much, or maybe every 18 months if you're a little bit behind on your stat mandatory training, which means you would have covered this, which means you should be able to know this at a drop of a hat. You've done the training 10 times if you've been nursing a good while. But I can't tell. I don't know what the answer is. There's the answer if anyone does want to know. It's probably a wet chemical. But I think the problem with that is that stat mandatory training doesn't change the ethos, it doesn't change the culture, and it becomes a tick box exercise. And tick box exercises just get done to completion. You don't necessarily buy into the process, and that's my worry about all of this. You know, true education that has change as part of it is delivered in a very different way. I googled inpatient diabetes nurses. My team were distraught that I didn't put a picture of them up, but c'est la vie, I think. Work is going to increase, and I think that from an education perspective, everyone's going to have to think smarter about how we deliver that education, because it'll be a revolving cycle of education that's needed. It won't be a once-off. And as you can see in technology already in the last couple of years, it will continue to change at a rapid pace. So we're only going to have to do more and more work. For anyone that hadn't seen the actual FAD document, which now gives about usually 90 to 90 days or so for NICE to come up with its final tag assessment on this. So it won't be very long. I think this is as final as it's going to look, apart from knowing which insulin pumps are going to be included in the actual pricing part of this. But by any estimation at the moment, it's looking like between 50 to 75% of people with type 1 diabetes may be eligible. For those that aren't eligible, the question is, do they end up slightly raising their HbA1c so they do become eligible? I think in practice, even across the 5-year time frame, you'll find that there's less people that want to take it up than are eligible. So I don't think it's going to be quite as much of a tsunami as I think everyone's concerned about, but it's definitely going to increase. And certainly for a large hospital setting, you know, the occasional pump that you're getting at the moment, so, you know, 2, 3, 4 a week, is going to be much more common. And you already know the questions that you get from this. I found this thing attached to them, I've just cut it. And you go, okay, we'll come and sort that. Or you get someone else that's in recess and I found this attached to them. We need to send them for through the CT scanner. What do we do with this now? I think that all of this is going to increase in volume. And so there's going to have to be more expertise. And any nurse, I'm sure you've already realized that any nurse that does diabetes is going to have to become an expert in insulin pump and CGM management. Now, I think that we'd all be happy that we're fairly tech savvy. You know, I'm a tech savvy person. I'm happy with most technology, but you give me an Android phone, you give me my work phone, I haven't got a clue. I literally open it and go, where are the settings? I can't even turn like onto silent. I can't do anything with it. And I think that I can understand how people then get concerned about technology. I think that it's how I look at an Android phone. I don't want to get it, let alone get it. And I think that will be a problem going forwards. Even the tech savvy amongst us are going to find understanding pumps difficult. And don't forget, we are embedded in diabetes. We understand it. To try and teach that to someone who just wants to get, look after this person with diabetes as well as everything else that they're doing, is going to be, again, difficult to get the education across. So I'm going to finalize by just touching on AI in inpatient diabetes care. So what's in use currently? So not necessarily inpatient specifically, but we've now got licensed programs that use AI to analyze digital retinal images to look for early disease retinopathy. We've got CGM algorithms that learn and adjust insulin, of course, with the hybrid closed loop systems. That will only expand. So as we get more data and the ability for AI to be able to interpret these algorithms and change the algorithm going forwards, you will also have CGM and insulin pumps that will adjust exactly the right time of the month period, so exactly the right time for recognizing when the patient is taking another course of steroids. So that's only going to increase. But even with, I guess, new terminology, case-based reasoning. So already trials in some hospitals for insulin dose adjustment. So you plug in the patient parameters and it recognizes that they've treated 500 people with a similar circumstance before and will suggest what to do in those circumstances. Machine learning and deep learning, so identifying people at risk of diabetes, is again already being done, looking at parameters across general practice and primary care and going, this is the person to screen for diabetes, even though they don't quite reach the threshold for screening yet. And also artificial neural networks. So this is where you would link and analyze disparate information. So you have multiple different systems that don't talk to each other, but actually you plug them into an AI neural network and it will combine that data and try to think and make sense of it. So a good example is diabetes diagnosis, which is already being trialed at the moment, but also, starting to think about connected pens and population surveillance. So I don't know, maybe a district nurse will be able to actually have all of the carers in the nursing homes doing the administration of insulin via connected pen devices. And then you have these artificial neural networks that collect all of that data, give you population surveillance, let you know that the insulin's been given on time for the certain patients and when it's not been given, or it's been given incorrectly, or the glucose levels are going up. Where are we likely to get to? Certainly, I don't think it's that long, hopefully, before we get some integration of CGM into hospital records. And I say this with, I guess, a slight tongue-in-cheek, because I think we're all aware of the desire for the NHS to become super digital. But anyone that tried to submit their NDA report in the last week will find out that NHS digital isn't necessarily all it's cracked up to be. But I think that I will talk about where we're likely to get to eventually, certainly, and that's integration of CGM into hospital records. Certainly that, Scotland, I think, are probably closer to this with the My Diabetes My Way and the fact that they already upload that app into the hospital records. So, but it is doable. The next step on from that is that the ability to analyze the CGM and the inpatient blood test together to support prediction models for hypo and hypoglycemia. So it will recognize the CGM, it will recognize the person's got an AKI because their creatinine's gone up, and then it'll predict whether or not they're going to have hypos, or if the CRP is through the roof, it might predict hypoglycemia in that context. So again, it's putting a couple of things together that would be quite difficult to do en masse. Again, risk prediction models for hypoglycemia in patients. Again, those with AKIs with a low baseline HbA1c that's been plugged electronically on nil by mouth status, or is being given a red tray because they have to be observed eating, low BMI, or even just recognizing that patient every time they've been in hospital for the last 8 out of 10 times they've had an inpatient hypo. That could all be done automatically and just highlight patients at risk of hypoglycemia. Even early warning markers for development of DKA in type 1. So again, dehydration, so urea rising, creatinine rising, or rising glucose levels in that context, or that context of nil by mouth and perioperative diabetes. Insulin dose adjustment nudges. So I don't think this will become fully automated for subcut insulin, because you need to speak to the person about those dose changes. But certainly this has already been done. I think it will expand, that it will recognize the glucose changes over time and the context of the patient and increase those insulin doses. Even variable rate with predictive dose adjustment rather than reactive adjustment will be a huge leap forward. So, it actually looks at the change over time and suggests or automatically just adjusts the variable rate insulin. Biochemical analysis, so to target education. So again, if you're seeing there's lots of hypos, it will just automatically give you an update to say, well, these ward areas will be needing education on hypos this month. And even with instant analysis, that could be automated in the future. So it will just scan for all the incidents that are recorded in a particular area and then automate which targeted education goes out that month to that particular ward area. So we have to be smart like this. We have to embrace this sort of technology when we're going forwards. I think the limitations for this, the human factors. So certainly disregarding AI nudges. Already people do that all the time. We know that most people switch off their hypoglycemia alerts on their CGM already because you just go, okay, that's nudging me too often. I don't want it. And, everyone gets click fatigue when they're doing electronic prescribing. Or that pop up in your screen, you don't read it. You go, out, go away. I don't want it here. Please, I just want to do my job. So human factors will always disregard some of those AI nudges and input. I think it will further de-skill clinicians and patients and introduce dependence in a way. But that's not to say we shouldn't move in this direction. There's certainly be costs with interoperability issues and being able to talk between systems, education and training with increasing complexity. And then I think I'd also just finalize by saying data is only as good as the input or the data collector. And we'd all recognize, and this is one case that's from May this year of a rising. So I was called about this time here, so actually it's the wrong time, about 11 o'clock in the morning, with a rising glucose level and a rising insulin requirement prior to the patient going to theatre. I only happened to glance at it and went, why? He's not needed that much insulin. Why has it gone up to 3 and 5 mils an hour all of a sudden? Let's just clean his finger and check it again and we'll do it. And of course it came back at being actually 2.6. He was severely hypo, and every single one of these glucose tests have been on a dirty finger. And it's so lucky we managed to capture this, treat it, so he can actually have his surgery the same day still. But you can see how easy it happens. You see those blips all the time, don't you? Like 3 minutes later, oh, it's 20. No, it's not. There's some glucose on the finger. It's actually still 3.4. So good examples again of that data input being absolutely essential to all of these systems going forwards. So I think to summarize and to kind of finish the pep talk to say that you guys are absolutely essential going forwards, I think inpatient care is absolutely going to still need diabetes specialist nurses more than ever. A personal plug from my perspective is I think that all teams should embed a specialist pharmacist. I think it's going to help you with the complications of medicines going forward and open up the pharmacy army to support your team. I think that, and I've put here senior decision makers because I think that's the right term. We need more dedicated senior decision makers to cover for the increase in inpatient diabetes cohort. And that's people that I'm not going to name whether it's a consultant, a registrar, a specialist nurse, a specialist pharmacist, a specialist dietitian, but people who can actually make appropriate decisions in those patients, we will need more of. I think medication will continue to become more nuanced and complex. The capacity for education is almost certainly going to be a challenge as diabetes becomes more specialist. And I think the final thing is to mention is that the aging population is going to mean more nursing care and rehab. And actually, I think your inpatient expertise is going to be required to either upskill community or to provide advice and context to the systems and the programs that people are thinking of inputting into those areas. That's me finished. Thank you very much. I'll stop sharing.
Thank you so much, Phil. That was a really, really interesting insight into what's to come, I think, in the inpatient diabetes era. And again, thanks to Jerry also for giving us a really nice talk about how far we've come and obviously where we've still got to go to. I'm aware of the time, but if anyone's got any final questions for Phil or anyone else, then just put them in the chat box. We've got just a couple of minutes just to round things up. And again, just like to thank everyone for tuning in today and for interacting and asking the questions. And hopefully you've learned a lot, because I certainly have, about the future of inpatient diabetes nursing. So lots of thank yous in there. So I will draw the meeting to a close and thank everyone for your time.